Okay, so we're in chapter 4, looking at page 69, and we're going to go over some lab values and some common reference ranges, and then look at the notes. So the first lab value that we're going to review is calcium. Calcium is abbreviated by Ca. So there could be total calcium or ionized calcium. Total calcium common reference range might be 8.5 to 10.5 milligram per deciliter. And the ionized calcium common reference range could be between like 4.5 to 5.1 milligram per deciliter. So the notes remind us that we can calculate the corrected calcium if the albumin is low, and we can refer to the calculations chapter for the formula. Correction is not needed for ionized calcium. And we will likely see higher levels if we are supplementing with calcium supplements, if we're supplementing with vitamin D, and if we're taking thiazide diuretics. We'll likely see decreased levels of calcium due to long-term heparin use, use of loop diuretics, bisphosphonates, cinacalcet, systemic steroid use, calcitonin, foscarnet, and topiramate use. There's a note here to supplement calcium in pregnancy, in osteoporosis and osteopenia, and with certain drugs. We can refer to the dietary supplements chapter. We can also refer to the natural and complementary medicine chapter. Alright, so the next lab value we're going to review is chloride. Chloride is abbreviated by Cl. Common reference range for chloride is 95 to 106 milliequivalents per liter. The note for chloride is that it is used with other labs to assess the acid-base status and also to assess fluid balance. The next lab value we're going to look at is magnesium. Magnesium is abbreviated by Mg. The common reference range for magnesium is 1.3 to 2.1 milliequivalents per liter. So the magnesium might be increased due to taking magnesium containing antacid and laxatives. The magnesium levels might be decreased due to proton pump inhibitors, diuretics, amphotericin B, foscarnet, echinocandins, diarrhea, chronic alcohol intake. The next common lab value that we're going to look at is phosphate, PO4. So the common reference range we should see for phosphate labs would be between 2.3 and 4.7 milligram per deciliter. Phosphate is usually elevated in chronic kidney disease, and it's usually low. Due to oral calcium intake, taking phoscarnet, and also low due to phosphate binders, taking phosphate binders. Next, we're going to look at potassium. So potassium is an electrolyte. Potassium is abbreviated by the letter K. And the common reference range for potassium is 3.5 to 5 milliequivalents per liter. So potassium could be elevated due to ACE inhibitors, taking ACE inhibitors, taking angiotensin II receptor blockers, taking aldosterone receptor agonists, aldosterone receptor antagonists, taking cyclosporin, tacrolimus, mycophenolate, taking canagliflozin, taking aliskiren. Potassium can also be elevated due to taking potassium supplements, obviously. Taking Bactrim, the sulfamethoxazole trimethoprim, can also increase potassium levels. Chronic heparin use, NSAID use, pentamidine, and drospirenone containing oral contraceptives. All of these medications can contribute to elevated potassium levels. Some medications that can contribute to low potassium levels would be diuretics, insulin, beta-2 agonists, steroids, conivaptan, mycophenolate. All right. The next lab value we're going to look at is sodium. Sodium is abbreviated by Na. The common reference range for sodium is going to be between 135 and 145, and this is milliequivalents per liter. Sodium could be elevated if a patient is taking tolvaptan or conivaptan. It could also be elevated if a patient is taking hypertonic saline. Some medications that could cause low sodium are carbamazepine, oxcarbazepine, SSRIs, diuretics, desmopressin. The next lab value we're going to look at is bicarbonate, or bicarb, or HCO3. So there are common reference ranges for venous and arterial bicarb. So the reference range for venous bicarb would be 24 to 30 milliequivalents per liter, The reference range for arterial bicarb would be 22 to 26 milliequivalents per liter. So bicarb, in terms of medications that could increase bicarb levels, so if you're taking a loop diuretic or a systemic steroid, that would cause increased bicarb. If you're taking topiramate, if you're taking zonisamide or salicylate overdose, those are medications or conditions that would cause decreased bicarbonate. And again, bicarb is used to assess acid-base status. All right, and then we have blood urea nitrogen, BUN. So then the common reference range for BUN is 7 to 20 milligram per deciliter. So the BUN, or the blood urea nitrogen, will be elevated in patients with renal impairment and patients who are dehydrated. And the BUN is used with the serum creatinine, the BUN to serum creatinine ratio, for example. So it's used to assess fluid status, and it's also used to assess renal function. All right, so then the next lab value is serum creatinine, which is SCR. The common reference range for serum creatinine is 0.6 to 1.3 milligram per deciliter. Serum creatinine is often elevated due to many drugs that impair renal function. So, for example, aminoglycosides, amphotericin B, cisplatin, cyclosporin, loop diuretics, polymyxin, NSAIDs, radiocontrast dyes, tacrolimus, and vancomycin. Some medications that can also cause a false elevation in serum creatinine would be Bactrim, H2 blockers, and cobicistat. Serum creatinine levels would be low in an amputation, in a hemodilution, and with low muscle mass. The last lab value mentioned on page 69 in the chart is anion gap, or AG. The common reference range for anion gap is 5 to 12 milliequivalents per liter. A calculated value, again, it's a calculated value, but it's often reported on the basic metabolic panel. we can review the calculations, part 4 chapter, for how to calculate anion gap. And as a reminder, an elevated or a high anion gap suggests metabolic acidosis.